facilities to support the learning process, including the training center building has more than 2,000 meter square areas with a hall that provides 500 seats and a comfortable inn. Auditorium has more than 3,000 meter square areas that provides 1,500 people that used as a multi-purpose building for both internal and external activities of Poltek lecture buildings. Integrated laboratory consists of laboratory department of nursing, midwife, nutrition, health analyst with adequate campus equipment. Campus gazebo with 128 meter square area. Bengkulu is a province in the southwest of Sumatra Island. Nature, culture, and history become one, and it's known as Bumi Rafflesia. Politeknik Kesehatan Kementerian Kesehatan Bengkulu was established on April 16, 2001. Poltekkes Kemenkes Bengkulu is ready to be an excellent health college that provides professional health workers and lead to global in 2025. Our alumni have worked domestic and abroad that spread in Japan for 63 people, Taiwan 20 people, Saudi Arabia 2 people, and Germany 1 person. Poltekkes Kemenkes Bengkulu is one of the excellent state health colleges in Bengkulu province. The main campus is addressed at Jalan Indragiri, number 3, Padang Harapan, Kota Bengkulu. Meanwhile, Campus B Curug is addressed at Jalan Sapta Marga, number 95, Teladan Village, Rejang Lebong, Regency. Poltekkes Kemenkes Bengkulu is equipped with the complete and modern campus facilities to support the learning process, including the training center building has more than 2,000 meter square areas with a hall that provides 500 seats and a comfortable inn. Auditorium has more than 3,000 meter square areas that provides 1,500 people that used as a multi-purpose building for both internal and external activities of Poltek lecture buildings. Integrated laboratory consists of laboratory department of nursing, midwife, nutrition, health analyst with adequate campus equipment. Campus gazebo with 128 meter square areas used for student discussion place. Tarbiyat Sihab Mosque has 457 meter square areas for 500 people with an open room design. Sport facilities. Unit of Language Development with Internet connection and 44 computers unit for computer-based tests and online TOEFL tests. A comfortable library with selfie corner and Selayang Anti-Korupsi corner. Unit of Information Technology that provides computer-based tests with 145 computers unit. Home theater that is used for audiovisual learning activities to all departments. Currently, Poltekkes Kemenkes Bengkulu has been accredited by BAN PT with predicate B, and it has 6 majors and 14 study programs that are already accredited by LAM PTKes.
Percayakan pendidikan putra putri Anda menjadi tenaga kesehatan profesional bersama Poltekkes Kemenkes Bengkulu. Poltekkes Kemenkes Bengkulu
Siap, kaku,
berkualitas, Polkeslu
bermulia.
Bengkulu is a province in the southwest of Sumatra Island. Nature, culture, and history become one, and it's known as Bumi Rafflesia. Politeknik Kesehatan Kementerian Kesehatan Bengkulu was established on April 16, 2001. Poltekkes Kemenkes Bengkulu is ready to be an excellent health college that provides professional health workers and lead to global in 2025. Our alumni have worked domestic and abroad that spread in Japan for 63 people, Taiwan 20 people, Saudi Arabia 2 people, and Germany 1 person. Poltekkes Kemenkes Bengkulu is one of the excellent state health colleges in Bengkulu province. The main campus is addressed at Jalan Indragiri, number 3, Padang Harapan, Kota Bengkulu. Meanwhile, Campus B Curug is addressed at Jalan Sapta Marga, number 95, Teladan Village, Rejang Lebong, Regency. Poltekkes Kemenkes Bengkulu is equipped with the complete and modern campus facilities to support the learning process, including the training center building has more than 2,000 meter square areas with a hall that provides 500 seats and a comfortable inn. Auditorium has more than 3,000 meter square areas that provides 1,500 people that used as a multi-purpose building for both internal and external activities of Poltek lecture buildings. Integrated laboratory consists of laboratory
program studi promosi kesehatan program sarjana terapan tahun 2020 sampai 2024 adalah
menghasilkan tenaga promotor kesehatan profesional yang unggul
dalam pemberdayaan masyarakat di tingkat nasional menuju global tahun 2024.
Misi yang pertama, mengembangkan manajemen tridharma perguruan tinggi yang profesional.
Yang kedua, menyelenggarakan pendidikan promosi kesehatan dengan keunggulan pada pemberdayaan ibu rumah tangga dan remaja.
Ketiga, menyelenggarakan penelitian dan pengabdian masyarakat, dosen dan mahasiswa yang mendukung keunggulan.
Yang keempat, mengembangkan kerjasama tridharma untuk mendukung kualitas jurusan di tingkat nasional menuju global.
Bengkulu is a province in the southwest of Sumatra Island. Nature, culture, and history become one, and it known as Bumi Rafflesia. Politeknik Kesehatan Kementerian Kesehatan Bengkulu was established on April 16, 2001. Poltekkes Kemenkes Bengkulu is ready to be an excellent health college that provides professional health workers and lead to global in 2025. Our alumni have worked domestic and abroad that spread in Japan for 63 people, Taiwan 20 people, Saudi Arabia 2 people, and Germany 1 person. Poltekkes Kemenkes Bengkulu is one of the excellent state health colleges in Bengkulu province. The main campus is addressed at Jalan Indragiri, number 3, Padang Harapan, Kota Bengkulu. Meanwhile, Campus B Curug is addressed at Jalan Sabta Marga, number 95, Teladan Village, Rejang Lebong, Regency. Poltekkes Kemenkes Bengkulu is equipped with the complete and modern campus facilities to support the learning process, including the training center building has more than 2,000 meter square areas with a hall that provides 500 seats and a comfortable inn. Auditorium has more than 3,000 meter square areas that provides 1,500 people that used as a multi-purpose building for both internal and external activities of Poltek lecture buildings. Integrated laboratory consists of laboratory department of nursing, midwife, nutrition, health analyst with adequate campus equipment. Campus gazebo with 128 meter square areas used for student discussion place. Tarbiyati Siham Mosque has 457 meter square areas for 500 people with an open room design. Port facilities. Unit of Language Development with Internet connection and 44 computers unit for computer-based tests and online TOEFL tests. A comfortable library, the Selfie Corner and Selayang Anti-Korupsi Corner. Unit of Information Technology that provides computer-based tests with 145 computers unit. Home theater that is used for audiovisual learning activities to all departments. Currently, Poltekkes Kemenkes Bengkulu has been accredited by BAN PT with predicate B, and it has 6 majors and 14 study programs that already accredited by LAMPTKes.
Percayakan pendidikan lab di Anda untuk menjadi tenaga kesehatan profesional bersama Poltekkes Kemenkes Bengkulu. Poltekkes Kemenkes Bengkulu
Siap kaku.
berkualitas Prokeslu.
Bahagia.
Sorry. Welcoming for Welcoming from Director of Poltekkes Kemenkes Bengkulu, Miss Eliana AKMN, MPH. And welcoming from Secretary of the Directorate General of Whole Personnel, Mr. Sugianto SKM, MSc, PH. Assalamualaikum warahmatullahi wabarakatuh. The Honorable Poltekkes Kemenkes Bengkulu, the respectable lecture office and audience. Good morning, ladies and gentlemen. My name is Nafila Fatiranisa, as Master of Ceremony on this special event, International Seminar with the time Community Empowerment in the Prevention and Control Non-Communicable Disease. First of all, let's thank to Allah Subhanahu wa Ta'ala who has given guidance, health, and forgiveness so that we can attend and participate in this special event without any hindrance. We also always pray to our Prophet Muhammad SAW, who has brought us to the path of light from darkness in this life. Okay, before starting our event, let's check how many people have entered our virtual room. Okay, almost 1,000 people in Zoom room and streaming on YouTube. Okay, we have some rules so that this event goes well the future. Firstly, participants are asked to stay in the Zoom room until the event is over. Furthermore, for all participants, please activate your camera and turn off the microphone. Okay, thank you everyone. Let's start this event right away. Firstly, let's say Basmalah to begin this seminar. Bismillahirrahmanirrahim. Secondly, sing the national anthem of Indonesia Raya. For all participants who join either via Zoom or streaming YouTube, please sit up straight. Okay, the next welcoming speech from Director of Poltekkes Kemenkes Bengkulu, Miss Eliana SKM MPH. Screen is yours.
Thank you. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning to all of you in this virtual room. Your Excellency, Secretary of the Director General of Health, Worker of Health Department, Ministry of Health Indonesia, Mr. Sugianto SKM MSc PH, the respectable Professor of Biochemistry, King Saud University, Prof. Nasser Al-Dagri, the Honorable Assistant Professor in the Department of Healthcare Administration at Asia University, Dr. Yu Ye, the Honorable all participants of this international seminar. Ladies and gentlemen, allow me and this opportunity to welcome all of the seminar participants by sending our grateful and praise to the Almighty Allah for all His blessing, grace, and mercies that have made it possible together in the international seminar with the topic community environment in the prevention and control of non-communicable disease. I'm Eliana, SKM MKes, Director of Poltekkes Kemenkes Bengkulu. On behalf of Poltekkes Kemenkes Bengkulu, I would like to say that it is an honor and pleasure for us to hold this big event on our campus. We are glad that you participate in the international seminar activity at the Bengkulu Ministry of Health Poltekkes, majoring in health promotion this time. I am very grateful to you, Professor Nasser Al-Dagri, and Dr. Yu Ye for taking time out of your busy schedule to attend this event. Is also want to thank the organizer for organizing this fantastic event. I am honored to welcome the speaker who participant in this activity. Thank you to Secretary of the Director General of Health Worker who have supported the event at us for the direction. Ladies and gentlemen, participants in this seminar are from health personnel, health promoters, lecturers, education personnel, and students. They come from not only Bengkulu province, but also outside Bengkulu province, such as Semarang University, Hasanuddin Province, Hasanuddin University, Makassar State University, Andala State University, Winsu, Halo University, King Saud University, Waynes State University, and others. The speaker of this seminar are Dr. Yu Ye, PhD from Wayne State University. The topic is Community Health Worker Certification Program and Healthy Promotion in Texas. Professor Nasser Al-Dagri from King Saud University. The topic is effects of 12-month hybrid in-person virtual education program in the glycemic status of Saudi youths. And Lisma Ningsi SKM NKM from the Health Polytechnic Bengkulu Ministry of Health. The topic, the application of the pra-model the latency group in an effort to hypertension management. Ladies and gentlemen, then we can Lee as the Secretary of the Director General of Healthy Worker to direction and to open this event officially. To all of our distinguished guests and participants, thank you for being here. Welcome and enjoy the seminar. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you so much, Ms. Eliana, for your opening speech. Next, welcoming from Secretary of the Directorate General of Health Personnel, Mr. Sugianto, SKM MSc, PS. Screen is yours.
Ya, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
To the owner, director of Poltekkes Kemenkes Bengkulu, with all the staff, the international and Indonesian guest speakers, and all participants. First of all, let us always give praise and gratitude to the presence of Allah Subhanahu wa Ta'ala for all the blessing and guidance that He has bestowed on us all. Because with His approval and permission, we are also in good health and can take part in the international seminar on the Bengkulu Ministry of Health Poltekkes with the theme Community Empowerment in the Prevention and Control of Non-Communicable Disease. Theme is in line with the challenge of 5 strategic issues which are priority in health development for the next 5 years, namely the maternal mortality rate or neonatal mortality rate, which is still high, non-communicable disease, tuberculosis, non-communicable disease, and complete basic immunization coverage. This international seminar is the right moment to remind us that the highest degree of public health will be realized if all components of the nation participate and work together. Ladies and gentlemen, based on the 2020 until 2024 program action plan issued by the Directorate General of Disease Prevention and Control, it is stated that in the last 3 decades, there has been a change in the disease burden from communicable disease to non-communicable diseases. This can be seen from the change in the main cause of lost disability adjusted life years or DALYs. The main causes of DALYs loss in 1990 were neonatal disorders, lower respiratory infectious, diarrhea disease, tuberculosis, and stroke. In 2017, the 5 main causes of lost DALYs were stroke, ischemic heart disease, diabetes, neonatal disorder, and tuberculosis. DALY loss due to stroke has increased from 5th place in 1990 to 1st place in 2017. With an increase of 93.4%, the sharp increase in DALYs loss from 1990 to 2017 2017 was mainly seen in diabetes, ischemic heart disease, and lung cancer. This is phenomena experienced by most developing countries due to change in people's socio-economic status, which lead to change in lifestyle. In general, risk factors for non-communicable disease are divided into the three groups, namely metabolic factors, consist high blood pressure, high blood sugar, obesity, dyslipidemia, impaired kidney function, maternal and child malnutrition. Second one is behavior factors, consists dietary behavior, smoking, occupational health risk. And the last one is the lack physical activity, namely alcohol consumption and environmental factors for the last factor. Unhealthy eating patterns contribute to NCD, food high in sugar, salt and fat, and low in fiber are contributors to NCD. The result of the 2016 individual food consumption survey nationally, the Indonesia population consumes risk category sugar more than 50 grams per person per day by 4.8%, and consumes sodium and fat at risk category more than 2.0 milligram and 14 until 67 gram respectively by 18.3% and 26.5%. The proportion of the population consuming less vegetables and fruit has increased from 93.5% in 2013 to 95.5% in 2018 from data Riskesdas. This indicates that the Indonesia diet is at risk for the emergence of non-communicable disease. To improve dietary patterns, effort to educate the public and cross-sectoral action need to be increased. This is the interesting effort how to make collaboration for other sector in health development. Smoking is another risk factor that contribute to daily loss. The prevalence of smokers in adolescents has increased from 7.2% in 2013. Riskesdas 2013 to 9.1% in Riskesdas 2018. This figure is further away from the 2029 RBGMN target of 5.4%. Another risk factor related to non-communicable disease is lack of physical activity. With economic, technological, and transportation advance, people's life tend to be sedentary, then followed by metabolic factors, namely hypertension, impaired blood sugar levels, and obesity. Obesity is a risk factor for other non-communicable disease that encourage the emergence of metabolic factors. The prevalence of obesity, body mass index more than 27, increased from 15.4% in 2013 Riskesdas 2013 to 21.8% in Riskesdas 2018. This is, be careful, the obesity increase dramatically in Indonesia. This is in line with the increase in the proportion of central obesity. Ladies and gentlemen, seeing the increasing concern about risk factor for non-communicable disease, especially metabolic factors and behavioral factor, strategic effort are needed, including increasing promotive and preventive effort, as well as educating the public regarding prevention of factors, increasing screening and early detection of NCDs in all health centers, their network and networks, strengthening community empowerment effort related to non-communicable disease control, improving service quality through strengthening primary health service as the front guard and referral system between FKTP and FKRTL, and increasing multi-sectoral action related to the movement Healthy Living Society. In Indonesia, we call Germas. To overcome the problem of NCDs, comprehensive and holistic intervention efforts must be carried out, namely promotive, preventive, curative, and rehabilitative, as a continuum of care. A strategic approach to reducing the burden of NCDs is increasing promotive and preventive effort through cultivating Germas, empowering communities in preventing and controlling NCD risk factors, increasing multi-sectoral action. Ladies and gentlemen, the Ministry of Health Polytechnic has a very important role in making a real contribution to improving public health status, including empowering the community in the prevention and control of non-communicable disease. I really appreciate to Poltekkes Bengkulu for holding this international seminar. It is hoped that the convening of the international seminar will strengthen step in institutional strengthening and continuous performance improvement with a focus on great excellence, so that Poltekkes can perform highly by producing innovation according to needs and contributing to health development. Once again, I would like to appreciate to Poltekkes Bengkulu to be held this seminar. It is hoped that the ongoing activities of strengthening Poltekkes will become the basis of the determining further development steps and the benefits of the existence of a center of action for the local community in particular and the wider community in general, especially for the prevention and control of non-communicable disease in the community. The Directorate General of Health Worker continues to strive to encourage institutional strengthening of Poltekkes through facilitating and monitoring with Kemendikbud's good learning best practices in the management and development of Center of Excellence that have been carried out other universities. Monitoring and evaluation and selection are carried out on ongoing basis. Poltekkes, which is currently one of the national priority program, is also given an award in the form of incentive for development costs, which are focused on strengthening institution, improving governance, and increasing output targets. Ladies and gentlemen, I would like to thank and express my highest appreciation for the presence of Mr. and Mrs. and the audience to take part in this international seminar. We hope that your active role will make a positive contribution to increasing the degree of public health, especially in the prevention and control of non-communicable diseases. Hopefully, what we are trying to do can be of benefit to all of us and for the progress of the nation and people of Indonesia. And Allah Almighty always provides guidance to all of us. finally by saying Bismillahirrahmanirrahim, the international seminar, Community Empowerment in the Prevention and Control of Non-Communicable Diseases, I declare it officially open. Thank you and congratulations on joining the international seminar. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you so much, Mr. Sugianto. We would like to present the certificate for Secretary of Director General of Health Personnel for Director Poltekkes Kemenkes Bengkulu. Screen is yours.
For Mr. Sugianto, we present you a certificate as a keynote speaker. Thank you so much. We really appreciate your speech. Thank you for your support to our event. Thank you, Mr. Sugianto.
Okay.
Okay, thank you
Thank you so much to Ibu Eli for your appreciation to me for certificate. Again, I would like to thank so much.
Okay. Ladies and gentlemen, in order to God blessing Allah Subhanahu wa Ta'ala, let's pray together. The prayer will be led by Anif Haskimiansa. Anif, screen is yours.
Assalamualaikum warahmatullahi wabarakatuh. Ladies and gentlemen, let us bow our head for a moment, pray to God, Allah Subhanahu wa Ta'ala, so that our international seminar can be precious to all of us. I will lead this prayer based on the teaching of Islam, and those who are not Muslim, you are pleased to pray according to each of your beliefs. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin. Hamda yu'afi'i ni'amahu wa yukafi'u mazida. Ya Rabbana lakal hamdu kama yanbaghi li jalali wajhikal karimi wa azimi sultani. Allahumma inna nas'aluka salamatan fitin wa afiatan fil jasad wa ziyadatan fil ilmi wa barakatan fil rizki wa taubatan qoblal maut wa rahmatan indal maut wa maghfiratan ba'dal maut. Allahumma hawin alaina fi sakaratil maut wa najatan minan nar wal afwa indal isab. Allahumma firlana wal walidina walil muslimina wal muslimat wal mu'minina wal mu'minat al ahya'i minhum wal amwat innaka sami'un qaribun mujibud da'wat ya qadiyal hajat. Allah, today Tuesday, November 22, 2022, in this virtual room, we gather here to bring about an international seminar with theme Community Empowerment in the Prevention and Control of Non-Communicable Disease. Allah, make this international seminar as a useful sense assembly, as a medium of sharing useful ideas, knowledge, and experience of scholars, researchers, and students of various disciplines. Allah, may the seminar we organize today benefit to our lives, broaden our knowledge, shine our ideas, and lead us to be successful, productive persons, which in turn will boost dignity of our nation. Allah, guide and bless our hearts and our minds with the light of your guidance. Impart your supreme wisdom upon our activities. Help us to speak our minds clearly. Help us to listen to each other, respect each other, love each other, so that we are included to the blessed person. Allah, you are the one who can fulfill our doa. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina azabannar. Subhana rabbika rabbil izzati amma yasifun wa salamun ala mursalin walhamdulillahi rabbil alamin. Amin, amin, amin ya rabbal alamin.
Amin, amin ya rabbal alamin. Okay, ladies and gentlemen, we will take a photo. Please for all participants to open camera. Please display slide. Belum ada, belum ada. Ma'am. Next. 1, 2, 3. Okay, ladies and gentlemen, we have checked 1,000 people who enter Zoom and 2,000 people watching streaming on YouTube. So what the next? The event that all participants have been waiting for. The seminar will be led by Ms. Ade Siska. As moderator, Ms. Siska graduated from University of Auckland in 2021. She currently is head of Language Development Unit and lecturer in Health Promotion Department of Poltekkes Kemenkes Bengkulu. For Ms. Siska, skin is yours.
Thank you so much, Ms. Master of Ceremony. Assalamualaikum warahmatullahi wabarakatuh. Good morning and ni hao, ladies and gentlemen. The Honorable Director of Poltekkes Kemenkes Bengkulu, the respectable Secretary of Directorate General of Personnel, our speakers from Taiwan, Riyadh, and Indonesia, distinguished participants, and all the audiences. Welcome to International Seminar managed by Health Promotion Department entitled Community Empowerment in the Prevention and Control of Non-Communicable Disease. My name is Ade Siska Filia, and I will be serving as your moderator today. Well, how are you, ladies and gentlemen? It's delighted to see you today. You'll be hearing a presentation from Professor Nasser Al-Dahri, and then Associate Professor Yu Ye and Mrs. Lisma Ningsih from Poltekkes Kemenkes Bengkulu. I'm sure that on this very timely subject, the speakers will deliver their speech in a few minutes. Well, ladies and gentlemen, today's international seminar will provide you with timely topics and outstanding speakers. Before the presentation begins, let me tell you how this seminar will run. Firstly, the speaker will present the material about 30 minutes, and after that, we will have question and answer session for about 15 minutes. And finally, the session will be ended by the conclusion. Now, moving along our first session, please welcome our first speaker, Assistant Professor Yu Ye. Before Yu Liuye present her material, I would like to introduce you a brief curriculum vitae of her. She finished her PhD in Nutrition and Food Science, Wayne State University, Detroit, USA. And then she has gained some certification, and the latest one is Community Health Worker Instructor Certification in 2019, Texas Department of State Health Services, Austin. And she currently works as assistant professor in Department of Healthcare Administration, Asian University, Taichung, Taiwan. And she also has several publications, and the current one is entitled Chinese Americans Family History of Colorectal Cancer Communication with Primary Care Physicians. Well, are you ready, Professor Yulia? How do I call you?
Yes, thank you so much for the great introduction. Can you hear me? Is the connection clear?
Yeah.
Okay, thank you so much.
Yeah. Okay, the screen is yours.
All right, thank you. All right, forgive me if this is not accurate. Selamat pagi.
Yes, selamat pagi. Thank you.
Good
Ni hao.
morning, everybody. That's probably the only thing I remembered.
Okay.
Thank you so much. It is such an honor for me to be able to present in the conference. Let me share my screen. Okay. All right. So, were you guys able to see the screen perfectly? Okay. If nobody said anything, I will guess this is a go. All right. So okay, can you guys still hear me? Yes, no. Okay, so I know I only have 30 minutes. Hello. Oops. Did I lost everyone?
Yeah, we can hear you.
Oh, okay, because
Oh.
for a second I thought I was kicked out because I can't see the screen.
Oh, sorry about that.
No, it's again, I blame that on the internet. So today my topic that I would like to share with everybody is the community health worker certification program and health promotions in Texas. So I just want to do a briefly, so since my background before I come to work in Taiwan, I was in the US for a while and I have a lot of experience working with community health workers. So I know while you guys were doing the brief introductions, we actually mentioned about community health workers, or as what we said, promotores. It's normally in Spanish, which mainly because the main community health worker population that work with is the minority populations that is normally underserved, and one of the huge part of them is Hispanic. And there are a lot of different names Under community health workers, it could be community navigators, health advisors, health ed, or even some outreach worker, depends on where or what the work settings they are. So they are essentials to Texas health, or even throughout the United States. They are trustworthy community members, and that is one of the reasons why when we talk about community empowerment, we talk about community health workers, because the role of community health workers is for us to educate the people that is in the local and like increase their health and awareness. And especially when we are reaching through the community members, they are more willing to listen to one of their own people. Some of their workload activity, including provide health education, health promotion, counseling, or community support. And they even work with all different health-related providers. They will enhance the access to community-based services, address social determinants of health, or provide more information to their communities. And regarding the incomes or the benefits, they also provided medical or health services or guidance while they provide those culturally appropriate assistance. So in the United States, just like a future background, everyone probably already heard that US, each state has their own different roles. So not all the regulations for community health workers are the same. So many states right now, they have been working on trying to build their own community-based workforce, and looking, of course, especially when we talk about community health workers, we talk about how would they be sustained, right? Like where do the fundings comes from and how would they work? So this is just a brief on, okay, so for example, when we talk about Texas, Texas is one of the states which I will be focusing on. Even though we have a state certified program, but we are not reimbursed through the Medicaid program. Instead, the fundings for all the community health workers comes from different grants, comes from different supplies of the local government, but just not the insurance plan. Okay, and the other example, which was in Michigan, which I worked previously before I go to Texas. So Michigan, they actually, community health workers is actually reimbursed through the Medicaid, which is their health insurance program. However, they do not have a certified program for them. So the community health worker, the trainings is based on different projects and grants, but there is no state certified certification. Okay, so this is just a little bit on the background. So why do we work with community health workers, especially through communities, and regardless of age? It could be through parents' pregnancies, younger children's, adolescents, all the way to adulthood. And the main reason is it is a successful utilization. So for all of you that has been working in the field, that has been reading articles, probably already know that this working with the community health worker model has been going on and on for probably like for the past like 20 to 30 years, and has been seen a lot of successful. It is also cost effective, it improves the health outcomes, and also it is would be capable for the organizations to develop more comprehensive health action plans, because by working with community health workers, we'll be able to work alongside with other organizations as well. And the programs also, of course, would address the health disparities more effective when using one-on-one outreach by the community health workers. So the process, especially when we talk about how do you become a community health workers in Texas? Of course, we go through a certification program, and currently in the entire United States, I think there are only 2 three actually, I think Rhode Island just come up, state that had state certified community health worker certification program. In other state, they would have, some of the state has certification program, but it would not be with the government. And some of them, like I mentioned, like Texas, like Michigan, it doesn't have that kind of programs, certifications in place. So after the training, you apply it through the US, so through the Texas State Health Services. And then after that, you will have your certifications for 2 years. And we'll talk a little on detail on how to maintain. So a certified course. So what do you need to become or to apply for the program or to be enrolled? To be a Texas resident, you will have to be 16 years or older, and under two different qualifications. The first one is training. So normally if you participate in a Department of State Health Services certified 160 hours program, and after you completed the program, you will get your certification. And the other one is based on your experience. So if the person has already been working in the community, with the community, and has community experience, we would count at least 1,000 hours accumulative. Of course, it doesn't have to be like all within 1 year. So it's 1,000 accumulated hours throughout a 3-year period. And if you have your supervisors that can verify that you have been working, they will have to provide evidence on these are the things that you are doing, then you will be able to apply without having to take the course. So what does the certification course included? So there are 8 main competencies that would need to be covered by the course itself, which is the communications, interpersonal, service coordinates, and all of them are listed over here. So for example, the communication skills, the reason why this is one is on the top is it's one of the most important skills that we would help the community health workers to gain or increase, like how to listen to your communities, right? Because there are verbal and non-verbal expressions of some feelings. How do you prompt the ideas or answers and have them are more willing to communicate with you? How to listen, like properly listen to your audience, to your community, and how to engage. So and these are some of the things that they will be learning throughout the certification programs. And I actually have a small video, and let's see if I can play it properly. Here. So these are the community health worker roles that was actually involved. Let me see. So among all of these 8 competencies, there are things that the community health workers would be working on and will be engaged in. So just going to play 2 that's most related to what we'll be covering today.
Information. This means providing information in the appropriate language and also in a way that respects the values and cultures of the communities that they serve.
I provide training and education for women and men from my community who speak Swahili. And because I speak Swahili and I come from the same community, it's much easier for us to be together and talk about the health issues.
See the video.
Oh, you can. Oh, here.
Okay.
Can
Thank
you guys see
you.
that now?
Yes.
Okay.
Really,
So
thank
the
you.
first workload and competency are talking about how to provide culturally appropriate health education and information, and what that is a shared experience from one of the community health worker.
The second role of community health workers is providing in the appropriate language and also in a way that respects.
I provide training and education for women and men from my community who speak Swahili. And because I speak Swahili and I come from the same community, it's much easier for us to be together and talk about the health issues like chronic diseases that we know it's a new thing when we come to this country. How can we be able to eat the right food because everything is different? So because I speak Swahili, it's much easier for my community to have that trust that we can sit down very casual and speak about the things that not every woman will just go to the doctor and spill out everything that's going on about their health.
Okay, so the first one would be talking about because they work with minorities, so communication, how to provide your health education within the proper language, right? And when we say, when we talk about proper language, it's not just the language that is actually spoken, but the phrase that we're using, the community health worker, like we mentioned earlier, they will be able to, they are from the community, they know the community, and they will be able to provide more information on top of that. And the second would be the implementation for from the communities, and this is also more related to non-communicable disease. So there we go.
The eighth role of community health workers is providing individual and community assessments. Many of the serious health problems facing communities today, infant mortality among African Americans, asthma among poor children, violence among youth, are the result of environmental, economic, historical, and social conditions. Because of the deep understanding that community health workers have of their community, their health concerns, and systems, community health workers are specially able to provide valuable assessments to improve health.
I've discovered that there's a high prevalence, of domestic violence amongst my community, especially women. And the way to handle this is by setting an assessment through questions. I set a few questions for the individual, and through these questions, it helps the individual really to come out with all that she has experienced. And many times I find also that there's some evidence from the individual herself, whereby she might have reported the issues or case to the police or might have gone to the court.
Okay, so that is what I wanted to give you guys, like because instead of me telling you guys what they actually do, I think it's easier for me to just show you some of the videos that they actually talk about what they actually done or actually did by the things that they learned.
So all this.
So okay. So what do how is the community health worker certification, like what we said, right? How to maintain. So once you receive your degree or the certifications, you also must complete a 20-hour continuing education program throughout your practice, like for every year. Otherwise, your certification would expire. And this is some of the material. So let's say just quickly scan through, which be probably you need at least 10 credits. That is actually from the Department of State Health Services of Texas. And you can have the other 10 that is non-state health services, but they are also considered as either self-learning. You can do it on, let's say, for example, going to related conferences like the ones that was just hosted, the American Public Health Association. That is probably one of the largest public health meetings around the world. Normally there's like more than 12,000 people that goes there every year. So one of their largest sections was actually community health workers. So if you went to the conference, you sit through all the different seminars, you can also claim some of the hours. Okay, so the program I actually kind of worked with is the Chinese community health certificate programs in Texas. And why did I mention this is a brief background. So because Texas has probably the largest Chinese American populations in the United States. I think it's the third right now. And according to the State Health Services, currently there are almost 4,000 community health workers in Texas. However, under that, 92 of them identify them as Asian and only 11 of them speaks Chinese, which is a huge gap here between the Chinese Americans, because based on the US data, 60% of the Chinese Americans are claim that they are immigrants, and about 40 of them, they said they have limited English proficiencies. So that is why we wanted to develop the programs in Chinese or in Mandarin, so that we can help them to help deliver these informations. And in addition, what we wanted to do is that, because cancer is actually the leading cause of death for Chinese Americans, so, and you guys can see the numbers for male and females, like for example, for male, it's like lung, liver, colorectal, or stomach cancer. And for females, in addition to that is breast cancer. So for that being said, the program I worked on, we actually developed a cultural and language appropriated certification programs for Chinese Americans in Texas. And that is focused on cancer. So what we actually did is we collaborated with the centers on and incorporated the 8 competencies that is adapted from an English version. We did update the content, translate the information to Mandarin, and at the same time, we need to change all the examples, all the pictures, and all the informations to provide the contents, and added new content that is related. So one of the skills earlier that we covered is knowledge. So for this training program, we actually focus on different cancer informations and knowledge, and on the prevention. So the training program, the total of 160 hours that I mentioned. So we kind of break it down into different workload. They have to do internship, they have assignment and homeworks, and they will have to do like a in-person workshop to be able to practice what they actually learned from the program. So, okay, this one I already kind of mentioned. So the recruitment is the training program that is we actually advertise right through local newspapers, radios, flyer, internet, and emails. And we actually were able to have them do online applications, and we ended up at that cohort, we trained 46 state certified Chinese speaking community health workers that was able to develop cancer prevention educations. So I'm just going to pick, so there are 5 different types of cancer that the community health worker actually learned throughout their training. But right now I'm just going to focus on one, because I know I have limited time, and which the one that we're focusing on, which is colorectal cancer. So the CHWs actually went into the communities that was enrolled and provide education. So they do face-to-face, also both in person and online. What they did is they teach the people like what is colorectal cancer, what are the risk factors that cause colorectal cancer, and how to collect the family history, since we know family history is a risk factor. And they help the participant to understand what is their risk of colorectal cancer, and if they need to do screening early. And by doing this, it's not just for adults, but for teenagers, adolescents as well. It's because if you are in risk for have a family health history of colorectal cancer, normally the screening you will start early. And they also provided like, general guidelines on their diet, on physical activities, and provide a personalized prevention counseling based on whatever information they collected or they gathered from when they were talking to the family. And even though we, when we promote the program, we told our community health workers, okay, go talk to your friends, right? To start with the friends, to start with somebody nearby that's close to you. But oftentimes when they are working, they will be working with the entire family as a whole. And I know this is a little off topic on what I presented in the slide, but when I was working at Detroit, so even though Detroit doesn't have a certification system, we actually work with community health workers, and that was the program that has been working with overweight and obese adolescents. So as if some of you guys already know, Detroit has huge populations of African Americans, and with the teenagers, they have 40% overweight and obese rate. So back then what we did was, and actually it was a really successful program, because I mentioned this is when I I was thinking about, okay, education, because I know this program talks about cancer, but the other weight loss program was actually really helpful for. So for those is we work with overweight and obese adolescents, and we asked the community health workers to go into the families once a week at the beginning to help the kids learn about nutrition, healthy food, and we even bring them a scale and to teach them, okay, so this is the things that we will record your scales. So every time we come in, they know they have to weigh themselves, and we provide them with, in addition to nutrition, teach them how to create their food menu, how to cook properly, or provide them with like guidelines on how to do physical activities. Because for some of the teenagers, if they are living in a non that safe environment, right, they would probably not, some of the physical activity like going to the park, walking around, or go outside to do some work, that would not be possible. So we will have to provide them with, like, again, in-person, personalized suggestions on, okay, maybe these are something you can do at home and you will be comfortable of doing. So at the end, we also see like a great success on the weight loss with the adolescents that we are working on in Michigan. And come back to the CHW in Texas, what we saw was, okay, so at the end of the 3 months that we asked them to serve, they actually served almost like 1,100 participants, which majority of them, they actually have a college degree or above. However, majority of them did say that they are born outside of the US, and their acculturation level was 1.9, which the range was actually 1 to 4. So it's kind of like in average, which is kind of consistent with the national data as well. And almost 90% say they do have health insurance coverage. So the colorectal cancer communication behavior that we asked our CHWs to deliver, after a 3-month follow-up, we can see that there is significant improvement on, okay, after they meet with the CHW, they were actually able to discuss or collect their family history of colorectal cancer. They were able to speak to a doctor or discuss their family history of colorectal cancer with a physician or with a family doctor, which is a huge improvement from our perspective. And we also see significant improvement through the 3rd month of their lifestyle on the reduction of red meat consumption and the reductions of processed meat consumption. Unfortunately, the exercise did not see any increase. Alcohol consumption is also fairly there, and not much difference or changes to the vegetable and fruit consumptions either. So this is what we actually gathered and seen, that they were actually being able to, so a community health worker was actually a successful model. They are willing to provide the services. I mean, within 3 months to 1,000 people, I would say that is a good chunk of success as well. And also I would like, again, one more short video. So this is in addition to the health promotion, health education, some of these HWs, they are working in different settings. So I do have a small video that talks about a day or a life that is reported from the community health worker. Say, okay, this is what I actually do in a day. So let me grab that as well. And use the day of a community health worker to end my speech.
Hi, I'm LaWanda Tinsley, and basically I am the community health worker here for UT Physician Center for Healthy Aging and Multi-Specialty Clinic. And basically what I do is I help the patients and the doctors and the nurses all to work on one accord. On a daily basis, one of the main things that I'm helping people with, insurance. You know, I thought I had this insurance, but I don't have it. I thought my insurance covered this, but it doesn't. We do the research. Having a community health worker actually keeps you from the patient from worrying about other issues that they might have outside of their health. If they can just purely focus on their health only at a time and someone else is handling all the other areas, that gives them peace of mind and they're able to actually comply with what the doctor wants them to do. A lot of times people don't come to the doctors because they don't have the way, and they don't know who to ask, where to go, and they just get a little discouraged. But when a community health worker, they bridge that gap. They get it out of the way and they're at peace.
You say you're gonna be calling me, huh?
I was already a community health worker before I came one. Didn't know it existed, didn't have a name. Cause I always go around trying to help somebody. I was just sitting there and I said, it's not about anything big or anything. Just want to do something different and with purpose.
Okay. So yes, again, once that is what community health worker does in the United States, and in addition to what I actually covered today on the obesity and the cancer.
Yang
sorry. No. Okay, so on the cancer studies, there are multiple actually different things that community health worker has been working on and focus on. So thank you all again. That would be all. And I didn't want to mention this earlier, but I did want to say I saw the news on the earthquake earlier, and I do wish everybody who is participated right now, wish you all well and wish all your family members are well, and prayers sending this way. Thank you.
Thank you so much, Yulia, for your very informative presentation. Yeah, we just have had the earthquake in one of the provinces in Indonesia, and now it's come to Q&A session. For the participants, you can raise your hand or drop your questions in the drop box. Well, there is one participant in here want to ask you a question. Her name is Saftaria Eliana. Saftaria, are you in here? Saftaria, can you please open your camera? Okay, maybe the questions from one of my friend in here. Oh, sorry. Yeah, there is a question in here. What are the challenges in giving training to the community health worker? That is the first question. Yeah.
Challenges, yes. I think one of the challenge that, I mean, at least when I face is because I specifically worked with Chinese Americans, and to be honest, the Chinese culture are not that familiar with community health worker as a concept. So just by having to let them know information and how to deliver that or pass that around, and is actually a main barrier. And one of the reason is I think it's a cultural barrier. Most barrier thing is they will think like, okay, health is a personal issue. I don't want people to poke into my privacy. I don't want other people to know health issues about me. So being able to how to teach or train the community health worker. Well, first to engage them to become a community health worker was actually a main barrier to start with. That was not, it was, to be honest, it wasn't that easy. And then after that, after they were engaged, how to train them to deliver the information to the community. I think that was one of my biggest challenge when I was working. Yes. Hope that answered your question. Yes. Dr. Villia, was that did that answer your question?
Yes. Sorry, we have a trouble connection in here. Well, there is a question in here from one of our participants. Her name is Miss Kinanti. Miss
Yes.
Kinanti, can you please open your camera? Are you in here with us?
Yes, I am here.
Okay. Please deliver the question.
Okay. I think it is very interesting thing that the community health workers in Texas were recruited with the standard requirement and then trained and even certified. Yeah, certificated. They get certificate. In Indonesia, we have cadre as a community health workers, but they work voluntary and they usually get less trained and also do not get certificate. My question is there any minimum target that must be achieved by the community health workers in Texas? Because they seem like very professional, in my opinion, from your explanation. And do they get any benefits like salary or health insurance from the government? Thank you.
Okay, no problem. So that is thank you, Kanenta. So that is actually a really good question. So what was happening right now is training and employment are two different things. So okay, let's say, for example, like the last person that was working in the UT health system. So she got her certificate as a community health worker, and she is employed through the UT health system. So whichever salary and benefit she received will go with the organization. And like I mentioned earlier, that in Texas, the community health worker, their position is actually based on different grants and different projects or different organizations. So it would be more like if the organization, let's say the hospital or the clinic, they wanted to hire community health worker, then the person they hired would need to be certified. So, and then the salary would be based on whichever organization that hired them. So just by getting the certificate, it's more like getting a bachelor degree. Okay, I get my diploma, but that does not guarantee I have a job yet. Yes. And regarding your first question on how many people they actually serve, no, it really depends on the project they are working on. So depends on the workload.
Okay, thank you so much for the answer. And the next question is from one of my colleagues.
Okay.
So many health promotion programs held by university of local government, but the drawback is that monitoring and evaluation are not sustainable. So from your experience as one of the community health worker, how should you measure the program in order to be success, and how to monitor and evaluate the program? Thank you.
So, well, I guess how you evaluate, well, yes, first of all, yes, I do agree, because that is actually, that's why at the really beginning, I did post a slide. Here, let me just share that. So that is actually a big issue and problems that we had, which was that the funding is not sustainable, right? So for that being said, how to, okay, if like on a good day, if the university get lucky, or the organization gets lucky, they will have new grants that works on different issues. Then the only thing that they will need to do is that they will probably have to, okay, say, for example, my grant, originally I work with colorectal cancer prevention. The next year, maybe the grant I got is for breast cancer. Then I would probably have to retrain my community health workers to get a different set of skills and still do the delivery. So if you say how to evaluate your program, then that will based on what your goal that you actually set up at the beginning. So what Texas they actually do, so all the community health work, so once you are enrolled, you have a roster that is sent out by the state of Texas. And if you are in the roster list, a lot of times it will actually provide you with, okay, there are job opportunities, there are other informations that you can look into that and see if you need or want to like get a different positions or like a different job. And the universities, sometimes they work with the local, so there are, if I remember correctly, there are almost 32 different training centers of community health workers in Texas, throughout the entire Texas. And some of them are facilitated with organizations, some of them belongs to the university. So those community health workers, they, instead of just working with one project, one department, or one professor, they probably work with multiple. So whenever people they need something, they will go to the center and say, okay, here's a project I'm working on, and I'm working with, let's say, Brazos Valley. Do you have community health worker that is actually in that area? So that's kind of like a little bit of like a benefit for keeping them still in the line of work.
Okay, we still have one more question in here. I will read it for you from the chat box. So the question is from Najmi. Good morning. Thank you for the opportunity. My name is Najmi Nil Faida. My question is, what are the most important basic things to be introduced to the community to protect themselves from non-communicable disease, especially for the coastal communities who are vulnerable to disease?
Basic thing to introduce the community to protect themselves from non-communicable disease. That's actually a really good question. I'm not that certain with the coastal communities, because I personally don't have experience working with them. But what I, based on my experience or what I learned, I think the basic knowledge of health and screening. I think these two are important because when you go through different age, you are in risk factors for different things, and you do go through different like annual physical checks or to see your how your body is performing. I think that is what I would consider as one of the important things that the community should know. I mean, health knowledge, like there are all these different types of information that is going on, and how do you, and especially like nowadays, how do you know the health information that comes to your cell phone, comes from WhatsApp or comes from Line? How do you know that is accurate? So how do you find the correct guideline and follow the correct guideline? I think for me, that is one of the important things that the community should know. Yes.
Okay, thank you so much, Yulia, for your very informative presentation and explanation. You are very talented and then very young.
I look young. Probably not that, but thank you so much.
Yeah, and the assistant professor, very young. So before ending this session, I would like to conclude some important points in here for your presentation. So your presentation is about community health worker certification program and health promotion in Texas. So the first one is community health worker is a crucial asset, especially in Texas. They increase the community's health and health awareness, as well as educate the community. So in here, they have to follow a certification course to be eligible to run the program. And there are about 8 competencies they have to gain in here, including communication skills and then interpersonal skills, service coordination, capacity building, advocacy skills, teaching skills, organizational skills, as well as knowledge-based skills. And in here, training community health workers is to serve the Chinese American. Well, before ending this session, we would like to give you a certificate of appreciation as our speaker in here. Yeah, for the community, please present the certificate. Yeah, we would like to take a picture.
Oh,
is it okay if we take a picture?
Yes, could you give me a second? I just realized, can you still hear me?
Yes.
Okay.
Is there something wrong in the certificate? Yulia. Sorry about the mistake. Yulia, are you in here?
Hi. Can you hear me?
Yes.
Oh, sorry, I think I just got kicked out.
Yeah, sorry about that. Okay, can you open your camera?
Oh, I thought it's open.
Oh, yeah. Okay. Now we are ready to take a picture.
Okay.
So 1, 2, 3. Okay, thank you so much.
Thank you. Can you send me the picture too?
Of course, yeah, we'll give it to your email too.
Thank you.
Thank you so much for your presentation.
Thank you so much. And it's, as I mentioned, it's my honor to be able to speak in such an important conference. And thank you again for inviting me. So thanks a lot.
Yeah, there are so many participants in here, not only in our virtual Zoom meeting, but also from YouTube. So we are very lucky to have you today. Thank you so much.
No problem.
Okay, see you in the next international seminar.
Yes.
Bye. Well, ladies and gentlemen, that's all our first session. Then we move along to our second session today with one of our outstanding speakers from Indonesia and of course from health promotion department of Poltekkes Kemenkes Bengkulu. So our next speaker is Mrs. Maningsi, SKM MKM. Before she presents her material, I would like to give her curriculum vitae. She graduated from Universitas Indonesia in 2013, and she currently works in Poltekkes Kemenkes Bengkulu as one of the lecturers in Health Promotion Department. And her current research experience is about fast food contribution toward obesity in the students of junior high school, as well as the relationship between maternal and child health services with the prevalence of stunting based on basic health research in Indonesia. So for Ms. Lisma, are you in here with us? Good morning, Ms. Lisma. How are you today?
Good morning, Mrs. Siska. Okay, thank you, Mrs. Ade Siska Filia, as moderator at International Seminar today. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. I am Miss Maningsi from Indonesia, specifically lecturer at Poltekkes Kemenkes Bengkulu. I would like to present our community health service programs in the special event. So I don't want to spend much time. Let me share the screen. Can you see my screen? Hello? Can you see my screen?
Yeah, it's very clear. Thank you, Ms. Lisma.
Okay. This is our community health service programs. The title is the application of PRA model to the latency group in an effort to hypertension management. And this is my team. This is Reka Lagora Marsapeli, Mrs. Wisuda Andeka Marleni, Mr. Darwis, Mrs. Ismiati, and Mrs. Husni. So I think my curriculum vitae has been shared by moderator. We go on to the next slide. Well, before I share about the application of PRA model, we have to know what about PRA model. Participatory plural appraisal model, which emphasizes the involvement of cadres and the community in all activities, starting from planning, implementing, and evaluating activity programs. The PRA method is an approach that invites the community to participate in the process of building and developing an activity. Okay, this is a location map of community health service programs exactly placed at Kabupaten Subdistrict, Kapahayang Regency, Bengkulu Province. Okay, why we choose the place? Let we share about analysis of situation. Okay, according to the table 3, number of hypertension in Kabupaten in 2019 very high. So this is the reason why I choose the location to our community health service programs. So, according to the midwife, one of the cases is the difficulty in regular monitoring because it is difficult to collect hypertension at post-bindu activities. And then lack of knowledge of cadres about hypertension. Cannot read. Okay, yeah. Okay, it's okay. Kepahyang Regency has a policy in the health sector. Our name is RPGMD, namely Health Promotion and Community Empowerment Programs, as well as non-communicable disease prevention and control programs. The solution take to overcome partner problems is to empower the community by forming a hypertension care group. The name is Latency, which is equipped with knowledge through training and mentoring. General purpose of community health service programs is empowering community groups is in managing hypertension in Baratwetan Village and Tansi Baru City, Kabupaten District, Kepahyang Regency, Bengkulu Province. This is special purpose, our community health service programs. Number one, identify the problem of hypertension in Kabupaten District. Okay, okay. Is it my voice clear? Okay. Next slide. Okay. Okay. This is our target audience in our community health service programs. There are 10 people for the latency group, and then 50 people of hypertension. Now, let me see the stage of activity with PRA model. Number one, we have to about planning, such as initial data collection, focus group discussion, recruitment and formation of hypertension care group, module development and training preparation. And then implementation, such as literacy group training, latency group training, focus group discussion, and assistant for hypertension. The last, that is evaluation. We collect final data collection, evaluation of PRA models. Result and discussion. Implementation of recruitment of latency group in collaboration with the head of the public health center and midwife, the selected latency group in cadre who is active and willing to participate in the community service process until it is finished. The latency group training was carried out for 3 days, virtually and offline. According to the table 4, we know about knowledge of the latency group before and after being given training on hypertension. As we know, that is increase before and after being given training on hypertension. The latency group that has been trained provides assistance to hypertension sufferers. Assistance is carried out at least 3 times. The latency group provides assistance to people with hypertension at least 3 times a month. There were 50 hypertension sufferers assisted by the latency group. You can see the documentation. The latency group teach the people about the latency application. Okay, the next slide. This is the application we have talked to the latency group. So we have to know what is the latency. Latency is an application used to check hypertension risk factor. The latency application or hypertension detection is an application used to check hypertension risk factor. In addition, this application is also equipped with hypertension classification feature, checks body mass index, information about hypertension diet, and information about the nearest health service. One of the activities carried out in preventing hypertension is through screening for risk factor and preventing hypertension through screening for risk factor for hypertension. Hypertension risk factors are an important part of the effort to control VTM in Indonesia to reduce the incidence of hypertension, and Android-based hypertension risk factor screening application was designed. This is based on research by Reka Lagora, one of lecturer in my team. How to use the latency application? Look for the latency application on the Play Store, then please download it. And then, if it has been downloaded, please register your identity. And then, please select the available menu. Then, the following is the display if you choose the check risk factor. The following is the display if you select the hypertension classification menu. The following is the display if you select the body mass index menu. The following is an example of calculating body mass index. The following is a display if you choose the hypertension diet menu. Okay, this is a documentation of our community health service programs, maybe a little bit. Okay, the conclusion is our community health service programs is the problem of hypertension. Hypertension was identified in Kabupaten district, and then identify the number and names of cadres who were trained and fostered to provide assistance to people with hypertension. The establishment of a hypertension care group, the name is Latency in Kabupaten district, implementation of latency group training in Kabupaten district, increase knowledge of the latency group about hypertension, implementation of assistance with hypertension sufferers by the latency group. The last, application of appropriate technology latency for early detection of hypertension risk. This is our recommendation from our community health programs. It is hoped that the activities that have been carried out can be continued at a routine program for the public health center in collaboration with village head, community leader, especially cadres in Kabupaten district. Public health center in Kabupaten district area to be able to empower the latency group as a community asset in hypertension screening. And then Kepanjang Regency Health Office is expected to include stakeholder involvement to make every community service activity successful. Okay, I think that's all I can say. I give back to moderator.
Thank you so much, Ms. Lisma, for your outstanding presentation for today. So we come to our Q&A session. I have a question in here from one of the participants. I will just read it for you. So, what the implications of PRA model for the hypertension? That's a very good questions.
Okay, the question
from Friska.
From
Friska in Kepanjang.
Oh, Friska in Kepanjang. Okay, Mrs. Siska, are you there? Okay, I think that's a good question from Siska in Kepanjang. As we know, not easy to reduce hypertension. We need to collaboration, we need cooperation with others, such as stakeholder, key person, people in community, and ATC. Through the PRA model, we can be close to the community, provide education on hypertension management. I think that's all.
Okay,
my voice, is it clear?
Yeah, maybe you want to re-answer the question. Ms. Lisina, you want to re-answer the question in case some participants didn't hear your voice.
Okay. Do you want I repeat again my answer? Okay. To Mrs. Siska in Kepanjang, I think that's a good question from you. As we know, not easy to reduce hypertension. We need to collaboration, we need to cooperation with others, such as stakeholders, key person, people, and community, and ATC. Through the PRA model, we can be close to the community to provide education on hypertension management.
Okay, thank you so much, Mrs. Mo, for your answer. Well, dear participants, I'm sure that maybe some of you need some relaxation. So we have ice breaking for about maybe about 3 minutes. Let's exercise. For the community, please share the videos so that the participants can share it.
Perhatian kepada seluruh sivitas akademika di lingkungan Poltekkes Kemenkes Bengkulu. Waktunya peregangan.
Siap, 7, 8. Atur nafas, ambil nafas dari hidung, buang dari mulut. Tamat peregangan dinamis. Masuk peregangan 1. Peregangan untuk tubuh bagian bawah. Kita ulangi arah lain. Gerakan terakhir dari latihan pendinginan.
Okay, now we come to the next session. We still have Q&A here. I have a question from one of our participants. So, Ms. Lisma, what are the challenges of this kind of program? Okay, the question is, what is the challenge or what are the challenges of this kind of program?
Okay, I got the point. This is question from Mutia. Okay, Mrs. Mutia, are you there? Okay. Our community health service programs, the implementation during pandemic. So we have to implement it, our program offline and online. So that is really mengganggu apa sih? This start. This. Okay, I continue my answer. That is really disturb our community health service programs. But during the pandemic, the literacy group conduct counseling through post-window activities, gathering as well as home visit, and then in addition to providing counseling, the literacy group distribute leaflet and teach people and community. Thank you.
Thank you so much for the answer, Ms. Lisma. So there is also one question in here from one of the participants, or maybe Ms. Karinda, you want to ask directly to our speaker today? Ms. Karinda in here. Hello, Ms. Karinda. Are you ready for the question? Or maybe you have an internet connection issue there? For the community,
Yes, ma'am.
Okay. Okay. Good. Good to see you. Okay. Now, yes. Please mention the question.
How to use the hypertension detection application?
Okay. Is that all your question?
Okay, the question from Karinda.
Okay.
Okay, I got the point. Let me share again. Oh, sorry. Okay, Mrs. Karanda, if you want to use detensi, we call them detensi to the detection of risk factor of hypertension, you must be look for the detensi application on the Play Store. Then please download it. And then if it has been downloaded, please register your identity. And then please select the available menu. Then the following is a display if you choose the check risk factor. So the following is the display if you select the hypertension classification menu. The following is the display if you select the body mass index menu. And then the following is an example of calculating body mass index. Last, the following is a display if you choose the hypertension diet menu. I think that's all I can say. I give back to moderator.
Okay, thank you so much, Mrs. Wan, for the answers. Actually, we have 4 questions in here. Let me see it in the chat box. Okay. I think no more question from the chat box, may be from other participants. Mr. Tony, you want to ask a question to Ms. Lisma? Mr. Tony, can you please unmute yourself?
Okay, thank you very much. You can hear my sound clearly? Hello?
Yes. Yeah, it's very clear, sir.
Great, okay. I just want to know, in terms of health promotion, what is the main effort to reduce hypertension, especially in rural or urban area? Is there any differences? That's all. Thank you very much. The question is clear?
Yes, it's very clear. It's
Yes, very
what is
clear.
the main
Thank you.
effort to reduce the hypertension, especially in the rural areas? Is that a question, Mr. Tony? Okay, for Ms. Lisma, maybe it's time for you to answer the question.
Your sound is not, I can hear your voice.
Sorry, Mr. Tan. Okay. I try to answer your question. As we know, not easy to reduce hypertension, but we need to collaboration and cooperation with others. So with the PRA model, we can be close to people in community, so we can give education, we can support, we can encourage participate from participant from other, from people in community, so they can be more educated, so we can teach how to control atau how to control about hypertension. So we can encourage people with hypertension can be routine to following at post-PINDU activities. Maybe that's all, Mr. Tony.
Okay, thank you so much, Ms. Lisma, for the answers. Well, participants, we still have 8 more minutes before the last session. Do you still have any questions? Maybe you can raise your hand. Yes, it's from Arvina Lia. Miss Arvina Lia, are you ready for the questions? Miss Arvina?
Yeah, I'm here.
Can you just please take out the mask so that we can clearly hear your voice?
Okay.
Please Could you please take out your mask, take off your mask? Yeah, beautiful. Okay.
Thank you.
Yeah.
Okay. May I know what are the drawbacks of the early hypertension detection from application?
Okay, so your question is what are the drawbacks
Yeah.
of this program, right?
Okay, thank you.
Most welcome. Yeah, we will wait for Ms. Isma to answer your question. That's a good question.
Okay, Mrs. or Miss Elvina ya?
Yes,
Miss
Miss
Elvina.
Elvina.
Okay, you answer the limitation of our program, is it right?
Yeah, the question is about the drawbacks or limitations of the program.
Okay. As we know, the program of community health service, our program will be implemented during pandemic. So the latency group must be home to home, to teach community, to teach people on community and teach how to use latency or detection respector. So the latency also give the leaflet to people with hypertension, so the people can be control hypertension. The people with hypertension can be come to post-bindu activities, but it's really hard to collect the people in the post-bindu activities. I think that's all I can say.
Okay, thank you so much, Ms. Misma, for your very informative and outstanding presentation today. So from your presentation, I would like to give some highlighted points in here. The first one is empower the community by managing hypertension in Kepahyang Regency, Bengkulu Province. And then there are some purposes of the program, including identifying problem of hypertension, and then forming a hypertension group. The next one is increasing the knowledge of hypertension group, and then give them the training. And the last one is monitoring and evaluation. Okay, before we end this second section, ladies and gentlemen, we would like to present you another ice breaking while we are waiting for the next speaker. Well, the following ice breaking is from the lectures of Poltekkes Kemenkes Bengkulu.
Kura kari. Ay, masak apa dah hariko yo? Kemarin lah masak ikan asin. Hariko masak apa dah? Perasaan ada tempoyak dah dalam kulkas kok. Ayo, pasnya ada tempoyak. Woi, mantap nian gulai ambore kok. Sip dulu rasanya. Ay, kurang asin. Garam dikit ya. Pasti mantapnya nih kok. Wah, pasti mantapnya nih kok. Mbak, nak, Sikola, kamu orang pasti suka kok. Mak masak gulai tempoyak, pasti enak kok. Mumpung masih anget.
Ayah apa mak? Woi, manggil-manggil tak penting nih makan puyak kok. Mana panen di luar? Ntar mak, beres dulu. Narok barang kok. Ini.
Assalamualaikum. Good morning.
Waalaikumsalam, Professor Nasser. Yeah, your session will be ready in 3 minutes. So before we come to your session, we would like to give certificate of appreciation to the previous presenter, Ms. Lisma. Yes. The certificate of appreciation is given to Ms. Lisma as a speaker to our international seminar. Maybe we should take a picture? Yes. 1, 2, 3. Okay, thank you so much. I would like to thank so much to our second speaker, Ms. Lisma Ningsi, for your informative and comprehensive presentation today. So, ladies and gentlemen, welcome. Sorry. Hi, Professor Nasser, are you already in our Zoom room?
Yes, I'm ready. Yes. Sometimes I hear you, sometimes not.
How are you today, sir?
Not too bad. I just feel cold, but I will do my best.
Yeah, it's still morning time in Riyadh, right?
Morning time, and I have a flu.
Yes. Okay, before you present your material, I would like to read your curriculum vitae. So, ladies and gentlemen, Professor Nasser Al-Dahri is a multi-awarded scientist in biomedical sciences, both at the regional and international level. And he's one of Stanford University's top 2% scientists in the world since 2020. So he has more than 500 scientific papers and abstracts with almost, 15,000 citations. Wow, that's incredible. And he has an age index of 63 and age 10 index of 265. Professor Nasser specialized in clinical biochemistry, metabolism, and vitamin D. So currently, Professor Al-Dahri is a full-time professor of biochemistry at King Saud University, Riyadh, Saudi Arabia since 2012. He is the former dean of the College of Science, King Saud University, and director of chair for biomarkers of chronic disease. And he is also a research fellow at University of Warwick, Coventry, UK, and a member of WHO Collaborating Center for Public Health aspects of musculoskeletal health and aging. So that's our speaker today. Hope you enjoy. Time is yours, Professor.
Thank you very much indeed. I'll go back to my slide. First of all, I'd like to apologize for my talk and my because I have flow. I will try my best to do it quickly as much as I can, and I hope you will understand also my voice. First of all, I would like to, I'm very sorry about what happened in the South Indonesia yesterday, and God bless you, all of you, and we are praying for these people to get safe. Second, I would like to thank the organized committee for giving me this opportunity to talk with you about our work. And I chose this talk to you, which have been chosen by the IDF in the next conference, also WHO, and I gave it in Dubai last week, and published in Netherland. And one of the interesting data we have done in the chair the last year. To start up with this talk, we have charity, which is Saudi Diabetic Charity. This charity is doing education program in schools and on the market. Also, they are doing education programs and some of the activity courses at the universities and colleges. And the question which is raised to them, did you get benefit? Did the patient and the diabetic people get benefit from your education programs? Because you did the last 10 years almost 80,000 program for education, and you trained the charity trained almost 8,500 teachers in the schools. So what is your KPIs? Did they get benefit from that or not? So the government start asking them these questions, and also from them scientists, also from the IDF. Did the patient? So the question is, how can we measure that? So the Saudi charity signed a contract with King Saud University to look for these questions and to answer these questions. Then we sit together with the Saudi charity people and with the scientists in the chair, and we make these proposals to do the effective 12-month hybrid in-person virtual education program in the Jassim state of Saudi patients. So our objective to determine the effective 12-month hybrid lifestyle education program on the glycemic status among Saudi children and adolescents, and our KPIs, our primary outcome is to measuring the hemoglobin A1C and the obesity status by measuring the BMI and also the weight and the height. So to do that, we choose almost 2,600 Saudi children over 60 schools in Riyadh area. Their age around between 12 to 18 years old, which is we choose it from this schools randomly, and we we follow them, these things, and we ended up of, because of the COVID lockdown, only 643. How we did get this number? The enrollment, as I told you, 3,000 from 60 school. We exclude 400 not meeting inclusive criteria, 130, and declined to participate 270. So the remaining is 2,600. Received this 2,600 received the intervention. They are respected in the school, and we, after 3 months, also we found that there are discontinued intervention and board compliance 22, lost to follow up around 37, so the remaining 2,541. After the 6 months, we did the discontinued intervention, our number around 8, and lost to follow up withdrawal of the 34, so the remaining 2,529. After 12 months, because of the COVID and the regulations, we wasn't able to call 1,846 children, and so remaining 643. Then we measure the diabetic status. So the intervention programs, I'll come back to this later. In the schools, really, before the lockdown, we used to go to them personally. We have good team in the Saudi charity, in the male section or in the female section. They go them regularly. They give them the pamphlets, they give them the educations, they give them the how to protect themselves, how to do the exercise, how to use the aids. So all students were given diet and exercise educations, including the standardized topics such as increasing their physical activity and reduce their body weight, discontinuing the juice, soda intake, bringing low-fat lunch, school, and decreasing portion size. To provide constant education across all the study staff were trained, and were supplied with the exact education program with our consultants. So studying were followed up for 12 months, 3 months interval during the study, and the student. Did you see my slide? It's okay. Hello? Can you hear me?
Yeah, yes, Professor.
The slide is okay? Moving?
Yeah, the slide is okay.
Okay.
We can see the slide.
So, okay, so the education material were in the form of pamphlets, booklets, video, and also some games. All education sessions have been done by pediatrics, endocrinologists, and also nutritionists, which is they are volunteer with the Saudi charity. The problem is when we had the COVID-19 lockdown, we stay about 1 year at home. So we changed the way of education programs, and we use all the media. At that time, we use Zoom, we use WhatsApp, we use Telegrams, we use Facebook, we use it to make a video and send it to the schools, we send it to the students, and to make programs. So really, we have a hard time that time, and we try our best to give them extra education programs while they are staying at home. So our aim is to change their lifestyle, to reduce body weight by 5%, to receive the carbohydrate 50% to 60% and fat less, about 30%. Receiving at least fiber intake, 15 gram, around 1,000 kilocalorie. Exercise over 150 minutes a week. Also, we tell them how to make exercise at home after the COVID lockdown. So then we take the baseline first. We take blood samples. We take anthropometric measurement, body height, weight, and all the information, diets. And after 1 year, after this intensive education program, we take also blood samples with the remaining 643 samples. And we measure the glucose, fasting glucose. We measure the hemoglobin A1C, which is the right definition by WHO, using the cutoff of that diabetic hemoglobin A1C, that's over 6.5%, around 48 millimole, or pre-diabetes between 5.7 to 6.5%, between 39 to 47 millimole, and the normal less than 5%, 5.7%, which is around 39 millimole. So from that one, from this 2,600 students at baseline were divided to follow. Diabetic group, we found they are 85, around 3.3% in the student. Pre-diabetic group, 227, which is around 9%. And normal group, 2,238, which is around 87%. After 12 months, we was able to collect only 643 because of the COVID of the student, and we were divided as follow. Diabetic group around 23%, and pre-diabetic 39, 6%, and normal group 584, which is around 90%. So this is after 6 months. And from the chart, as you see here, in the baseline, we found 9. We divided to 3 groups: diabetic, pre-diabetic. Diabetic was 20 in the baseline. After post intervention, 11 of them become normal, and 5 become pre-diabetics, and 4 still diabetic, which is good. Yeah, that's mean the program's intervention is good. The pre-diabetic in the baseline was 39, and after one post intervention, which is after 12 months, this 34 become normal. 2 still pre-diabetic, and 3 diabetic. And in the normal, we found 584 is normal. After 6 months, only 475 become normal. 60 become pre-diabetic, and 49 become diabetic. We ask these people about the physical activity, physical activity. So we found that these 20, 9 of them said no, they didn't use any physical activity, and 11 they said yes, we use physical activity. The pre-diabetic, which is the 39, 21 they said no, we didn't use physical activity, and 18 they said yes, we use the physical activity. And the normal, we found 312 they said no, we didn't use physical activity, and 272 they said yes. So 11 out of 20, which is 55% participant in the diabetic group, become normal glycemic post-intervention. 34 out of 39, which is 87% participant in the pre-diabetic group, becomes normal glycemic post-intervention. 49 out of 58, 584 which is around 8.5%, and the normal group becomes elevated to diabetic groups, which is a good. That's mean they have good for education program. So results at the baseline based on their BMI were divided into 3 groups: 17% obese, 18% overweight, and 64% normal. The change in the obesity after intervention, 35% student shift to be overweight, 3%, around 3% turn into normal, 61% stay obese as it is. In the overweight group, 48.6% they turn to normal BMI, 49 students remained as it is, overweight, and 2% student becomes obese. The normal group, 372 student remains normal, which is 95%. 5% student turn to overweight, and 0 student becomes normal. So the changing the BMI level according to the BMI status is found as control according to, so all over weight as 4 out of 64 days becomes normal, which is good in post intervention. 6 out of 9 pre-diabetic overweight baseline becomes normal post intervention, and also 35 out of 91 overweight becomes the baseline becomes overweight. So this is mean they're changing in the hemoglobin C. There is a changing in the obesity status, and according to physical activity they are doing after the nutrition. So the conclusion of our study, this lifestyle intervention program was an effective means for reducing the risk of type 2 diabetes among youth with elevated hemoglobin A1C level. The revision to normal status was in parallel with the improvement in participant of the BMI. This study, I mean, if you want further results of further, you will find it published in Children 2019, and also in 2022, and also it's published in Nutrient if you want further results from this study. And sorry again for my voice, and I hope I cover my talk. Thank you very much for giving me this opportunity to meet with my friends and sister brothers in Indonesia, and we hope this will be starting for good collaboration with these people. Thank you very much indeed. Any questions?
Thank you so much, Professor Nasser, for your great presentation. So let's come to question and answer session. I will read the chat box for a while, if you don't mind. Well,
Yes.
for all the participants, you can also drop your questions in the chat box, or you can raise your hand. Do you have any questions, all participants? Professor, would you please open your camera for a while?
Okay, because I didn't have good face, but I will do my best.
Okay, for the participants, do you have any questions so far? Maybe the community can check the chats in the YouTube in case there are some questions dropped there. Okay, Professor, I have a question for you. So,
Yes.
what are the challenges of your study?
Wow, the
Yeah.
main challenging is the COVID-19.
Oh,
And we're
yeah.
supposed to continue this with all the students. But because of the COVID-19, we have two challenges. First of all, to enroll and recruit good number to get to see the benefits of this intervention. Second, to remain the education program as it is during the COVID-19. So we did our best to make this program continuous even through the COVID-19. So really we have hard time. We did around more than 260 lecture during that time. And also we taped almost 45 video instruction to send it to them from 3 to 4 minutes by WhatsApp. So this is give us hard time, maybe.
Okay, so how to, oh, sorry, Professor, there is a question in the chat box. I will read it for you. So how to manage the complicated diabetes with kidney disease?
Well, this is the questions, but it should be answered by consultant, and I'm not physician, I'm biochemist. And really, if the diabetes is not controlled very well from the patients, yes, it will damage the kidney. 50% of the diabetic patients, they are doing, they have problems in the kidney because of the uncontrolled diabetes.
Okay, maybe this is the last question. Do you have any suggestion for the further study? Yeah, Professor, do you have any suggestion for the further study?
Yes, we will continue 3 years follow-up this year. Hopefully we get results, inshallah, end of this year. So we will go back to them now after the opening and see whether they are still have the same information, same activity, and same progress.
Okay, one more question, if you don't mind, Professor. It's from Mr. Tony. Mr. Tony, can you deliver your question to Professor Nasser? Hello, Mr. Tony. Are you ready for the
Okay,
question?
thank you.
Yes.
You can hear my sounds?
Yes, that's very clear.
Thank you, Professor. It is a good presentation. But I would like to ask you, what is the main causes of glycemic index status, especially for children in your study? Because in Indonesia, most of our children caused by consumption of food, especially in high glycemic index. Thank you.
Yeah, we are the same. We have the same problems. The same. The main things is, as you see here, increasing the BMI. With increasing BMI coming from increasing carbohydrate, and because of this fast food and this carbohydrate, soda, and drink, there is increasing the BMI. So this is the main issue. So this is what we concentrated in our education program in this course.
Okay, do you still have questions? Participants, do you still have some questions? I think there's no more question, Professor. Well, I would like to give some highlighted points from your presentation. It's about the effect of a 12-month hybrid in person. In this case, it's in person and virtual. This is education program in glycemic status of study of Saudi youth. And then it is a 12-month school-based intervention study. And all participants receive lifestyle education at baseline and at every 3 months interval to improve diet and exercise behavior. And this hybrid lifestyle intervention program modestly reduces the risk of T2DM among youth. Okay, Professor Nasser, we really appreciate your presentation today. So before ending this session, we would like to give you a certificate of appreciations. And if you don't mind, please open your camera because we will do a photo session for a while as a documentation. So we present you a certificate as a speaker in International Seminar of Health Promotion Department. Okay, we'll take a picture. 1, 2, 3. Well, thank you so much, Professor, for your interesting and informative presentation. I hope we can see you again in the next international seminar.
Of course.
And maybe
Of
one day
course.
you can come to Indonesia.
Of course. I will do my best to come.
Okay.
Thank you. Thank you very much.
Yes. For all speakers, we would like to say thanks for your participations and also for all the participants. Thank you so much for your active participations in our virtual room as well as in YouTube. Well, we come to the last of our session today. As the moderator of today's international seminar, I would like to apologize if I made a mistake. So you can, for the participants, you can fill the link of attendance list. It's in the chat box. I think that's all for today, guys. Thank you so much for your attention. Assalamualaikum warahmatullahi wabarakatuh. Good day. Ni hao, xie xie. Back to Master of Ceremony today. See you. Bye. Have a nice day.
Okay, thank you very much, Miss Siska.
Bye-bye.
Ladies and gentlemen, we finally come to the end of today's agenda. Let us close the seminar by reciting Hamdalah. Alhamdulillahirabbil alamin. Thank you, the speaker who have provided material, and to participants who have listening to the seminar from start to finish. I hope we can meet at the next international seminar. I, as Master of Ceremony, say goodbye. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Goodbye, everyone.
Goodbye.
See you in the next international seminar. Thank you for participating in our seminar.
Kamu orang pasti suka kok. Mak masak gulai tempoyak. Pasti enak kok. Mumpung masih anget.
Ya apa mak, manggil-manggil penting nih makan puyak kok. Mana panen di luar. Ntar mak, beres dulu. Narok barang kok. Ini. Alhamdulillah makan tempoyak kita hari kok. Bela nak, kita makan gitu sih nak.
Cepet, Siko.
Iya. Lama pula mak kau datang masak tempoyak.
Iyo biasanya kerasin kayak kamu.
Iya. Ikan pendam. Airnya mana kok?
Bapak kok mumpung di pasar kok udang kok lagi murah. Dalam kulkas tuh ada tempoyak.
Lah cocok pula.
Sayang loh, udang di dalam kulkas tuh dianggur itu jadi tempoyak udang.
Lah iya nian pula. Banyak-banyak dikit mak. Iya, lah jarang pula mak kau yang masak tempoyak. Nah, jangan banyak nian mak, jadilah pula.
Biasanya kalau tempoyak kok.
Mana gulai tempoyak?
Banyak makan kok.
Oh, pelan nak, makan gitu nak. Ambo duluan makan. Makan pula tempoyak. Bacanya pula mak kamu masak kok.
Jadilah, kau diet.
Panen.
Mantap.
Mantap, Pak.
Assalamualaikum.
Waalaikumsalam.
Assalamualaikum Bu Endang. Wah, soalnya asik nian Bu Endang. Lagi apa tuh Bu Endang nengok-nengok HP?
Iyo Pak, itu ada joget untuk baru. Masuk Pak.
Panas benar itu. Saya ikona. Saya kok tadi barusan dari puskesmas. Jadi informasi dari pihak puskesmas. Ada penyuluhan kesehatan selama pemeriksaan sekalian.
Woi mantapnya nih tuh Pak, di mana Pak?
Jadi rencananya besok itu sekitar jam 10 pagi. Jangan lupa besok itu keluarga yang lain ya.
Oh besok ya. Boleh ya bawa tetangga-tetangga juga tuh besok?
Itu malah lebih bagus.
Oh ya jadi.
Sudah ikutlah Ambo nak keliling lagi. Kirim ke tetangga sebelah kita.
Ya jadi Ambo besok datang urutan pertama ya, nak duluan ya.
Besok di aula kita ya.
Ya, jadi.
Ambo permisi dulu ya.
Ya.
Assalamualaikum.
Waalaikumsalam warahmatullahi wabarakatuh.
Yuk, ada undangan nggak kemarin dari Pak RT?
Oh ya Allah, untung kau ingatkan. Iyo nih jam 10 kan?
Iya, kelakuan apa ya jambo ya yuk ya?
Ayo, kita solek dulu.
Jadi juga tuh.
Cantik-cantik ya? Ya. Jadi, Ambo ndak beres dulu. Cacam lah rame orang, cepetlah dikit.
Oh maaf Ibu, dari mana ya?
Kami dari dusun.
Dusun. Oh di sini ke sini ya? Oh ya. Kenapa nggak pakai masker ya Ibu?
Lipstik kami kelak tak tengok on.
Nanti kita kalau mau foto kita pakai masker. Ya tentu saat ini kita masih menerapkan protokol kesehatan ya Ibu.
Oh ada masker kami Bu.
Oh ya silakan Ibu dipakai. Oke, mari Bu. Nanti kacamatanya dilepas ya Bu.
Boleh di depan tuh Bu.
Oh boleh. Boleh.
Kami duduk di depan Bu.
Ya silakan Ibu.
Jadi ibu-ibu, hipertensi itu adalah suatu keadaan di mana darah kita itu melebihi dari batas normal. Ya. Nah, seperti di sini. Gejalanya itu seperti kelelahan, sering marah-marah, sering berkeringat, terus penglihatannya mungkin buram, ya. Lalu detak jantungnya itu tidak beraturan. Saya menghimbau bapak-bapak dan ibu-ibu untuk rajin memeriksakan tekanan darahnya secara rutin.
Ibu Endang.
Yo Bu. Ambo duluan, ya. Pak dulu giliran kau. Ayo Bu Endang. Ya. Makasih Bu.
Ya, hari ini sekarang kita melakukan pemeriksaan ya Bu. Pemeriksaan yang pertama adalah kita akan menensi tekanan darah Ibu.
Oh, tensi itu yang mana Bu?
Pakai alat ini Bu.
Oh ya.
Ini tangannya Bu, tolong.
Kiri kanan?
Kiri aja dah Bu.
Oh kiri aja.
Ya. Aktif bekerjanya yang mana Bu?
Kanan.
Kanan, kiri aja.
Sudah pemeriksaannya, Bu?
Sudah, Bu.
Gimana hasilnya?
Berapa tadi, Bu?
Sudah 140/90, Bu.
Nah, tinggi tidak itu?
Udah masuk hipertensi itu, Bu.
Alamak, ngapunya kayak itu?
Iya. Ibu ada HP Android?
Ada, Bu. Kami galak nonton TikTok.
Nah, coba Ibu buka HP Android-nya, nanti saya ajarkan install aplikasi untuk mendeteksi faktor resiko hipertensi.
Kami kira tadi Ibu nak nengok TikTok kami, nak follow kami. Enggak, Bu. Kami buka dulu, Bu. Nah, Bu, kita download. Iko ya, Bu, aplikasinya.
Iya, Iko. Sekarang Ibu masukkan data, nama, jenis kelamin, sama tanggal lahir, Bu.
Oh, ndaknya galau itu yo?
Iya, Bu.
Oh. Dem, Bu.
Terus di sini kan ada beberapa kotak, Bu. Ibu klik yang ini, Bu. Cek faktor resiko.
Oh, ya.
Coba Ibu jawab pertanyaannya, Bu.
Apakah ayah ibu kandung menderita tekanan tinggi? Ya.
Jawab terus, Bu. Sampai 6 itu, Bu. Nah, Bu, skor Ibu 12. Artinya di sini Ibu beresiko menderita hipertensi, Bu.
Alamak, cacam.
Jadi setelah ini Ibu harus perhatikan makannya, Ibu ya. Terus harus rajin periksa ke tenaga kesehatan terdekat, boleh ke bidan atau ke puskesmas, Ibu ya.
Cak mana kok? Iko tidak boleh makan santan lagi.
Boleh, Bu, tapi jangan terlalu sering.
Ambo kemarin baru masak tempoyak udang.
Nah, Ibu, jangan tiap hari ya, Bu ya. Kurangi,
Alamak.
ini kan ada kan, kurangi konsumsi garam. Dietnya harus yang sehat, Bu.
Jadi rebus-rebusan baik ya?
Bening-bening.
Oh.
Cukup, ya, Bu ya.
Jadi.
Jangan stres, Bu ya. Ibu caknya galak marah-marah kok.
Oh iya Nian, bapak di rumah tuh memang tegalau Nian. Kemarin lah sudah periksa kesehatan. Nah, Riko masak sayur bening bae dulu. Biar sehat kalau toboko. Riko makan sehat dulu gitu. Mbak! Melin! Indah! Mama makan!
Alhamdulillah makan.
Makan. Kita makan dulu, Mbak.
Lah ngapa kau gulanya lah berganti? Kemarin enggak
Kan makan.
gula yang kau bening itu apa namanya?
Iyo. Kemarin tuh lah cek kesehatan. Kece ibu petugas di puskesmas tuh. Jadilah makan sayur bening kok baik. Yo, nah kelak kita cek kira-kira kalau kita kudar tinggi apa tidak tuh dari aplikasi detensi kan. Coba Mbak tengoklah dulu. Kok dari kece orang puskesmas kemarin, Mbak. Coba Mbak tuh tengok dulu. Kira-kira resiko hipertensi apa tidak.
Coba nak tolong nak.
Ah.
Aku ngerti nih.
Jadi Pak, di aplikasi detensi ini banyak yang menunya Pak. Ada menu cek faktor risiko, kayak ada pertanyaan-pertanyaannya, kelak kita jawab sama-sama Pak. Mangko ini ada klasifikasi hipertensinya Pak. Kita bisa ngitung IMT juga, ada diet hipertensi Pak. Mangko ini depan susah-susah lagi kita Pak nyari layanan kesehatan terdekat, ada di sini juga Pak.
Coba cekkan dulu ke kiro, cek mana? Kalau darah tinggi.
Kelak kita cek sama-sama Pak.
Nah, itulah kece ibu puskesmas kemarin tuh.
Lah darah tinggi Mbak kok.
Nah, pas lah.
Itu kau bisa lupakan tanganku, tapi tidak mimpi-mimpiku. Kau bisa, tak akan lama. Kau bisa